Thanks, Anthony, and thanks for the excellent timekeeping. Really appreciate it. Unfortunately, Anne wasn't able to join us, so I'm going to be the fill-in. Obviously, impossible to fill in Anne's shoes, so I'll do my best as we move into this second session. Now, although many of our clients really would love to have that medication that assists in methamphetamine use disorder treatment, we know that even if we do find one that it works and works really effectively, it's never going to be all of the answer or all of the solution. So we do need to be putting our efforts into other kinds of interventions along the spectrum of use disorder, but also together for people with severe methamphetamine use disorder that might be also looking for a medication to assist in that medication, but also for the whole range of treatments that are out there. So we're moving on now to the psychosocial intervention components of methamphetamine use disorder. And I'm hoping that we have Alison here with us. Thank you, Alison, who's the trial coordinator at the University of Wollongong, and be introducing her projects on methamphetamine and mutual support, a mixed method exploration of smart recovery participants' characteristics and opportunities for enhanced referral pathways. Thanks, Alison.
Thank you very much. So just in the process of sharing my screen.
Alison, we can't hear you very well, sorry.
Can you hear me okay now? Is the volume better now?
Not very well, actually. Sorry.
Is that a little bit better?
Yep, I think that should be fine, unless you can somehow turn your microphone up somewhere.
Yep, I'll try. Hopefully that's made a difference. Okay, so can everyone see the... Apologies, take two. This happened last time round that I did a presentation. Okay. Hopefully that's working okay, and hopefully people can hear me okay. I'm not quite sure what's going on with the audio. So thank you very much for coming along today. Really appreciate everyone being willing to attend. Really important area that we're talking about today. A couple of quick acknowledgements to begin with. Smart Recovery Australia, who we worked with on this project, and then funding through the second round of the NCCRED seed funding grants. Also really important to acknowledge the expertise, the mentorship, the support of the rest of the research team. So a little bit of background to begin with for this project. We know that oftentimes people who use methamphetamine tend to delay or avoid seeking help for their treatment, for their use of methamphetamine rather. And unfortunately, this means that it's going to compound those individual, the societal, the economic harms associated with methamphetamine. Because oftentimes people tend to engage later in the course of their use, or perhaps there's also a disproportionate emergency crisis use of services. Some of the barriers that have been identified, things like stigma, embarrassment, shame, not viewing methamphetamine as a problem, and then also really practical things around access, for example, so cost, waiting times, availability. We know that there is some positive outcomes that are possible from psychosocial treatments, reduced use, reduced harm, improved mental health outcomes. And so there is a bit of a discrepancy between what is potentially possible and then what's actually happening out there within society. And that was one of the things that led to our interest in this particular research, is how do we improve people's engagement with treatment and support to be able to improve their outcomes. So our interest in particular was about, sorry, I've just seen that my voice needs to increase. Is that better? Before I move on to the next slide, can someone let me know whether or not that audio is a little bit better?
Definitely better from my point of view.
Okay, fantastic. Thank you. Apologies for that. I'll just see if I can turn it up from there. Okay, so apologies for ongoing technical difficulties and audio, but thanks for sticking with us. So as I mentioned, our interest is in being able to improve people's engagement with treatment and support. And so in particular, we were interested in the role of mutual support. So mutual support, you might be aware, is that reciprocal exchange of the social, yay, I'm just seeing a great come up, is the social, the emotional, the informational support that people give and receive when it comes to addictive behaviours. So you might be familiar with Alcoholics Anonymous or Narcotics Anonymous. They're some of the most familiar methods for being able to access mutual support. But there is other options available, and Smart Recovery is one of those options. And so we were interested in the potential role of Smart Recovery, not only for engaging people in treatment and support, but also potentially linking them with the treatment sector more broadly. Couple of things, it's anonymous, it's peer driven, so that might overcome some of those barriers around stigma and shame. It's a range of addictive behaviours, so even if people don't see methamphetamine as a problem, they might be willing. And then it's also grounded in CBT and MI, which are evidence-based approaches to a range of behaviours, including methamphetamine. It's also really highly accessible. So in terms of the aims of this project, we wanted to understand whether or not people attend Smart Recovery groups, similarities and differences, what are some of the characteristics that might be associated with attending, how does Smart Recovery fit, not only in terms of people's own individual use history, but also the broader treatment and support system, and then also how do we improve engagement in both Smart Recovery and treatment and support more broadly. As many people would appreciate, COVID hit, and unfortunately that meant a few modifications to the way that we're approaching things, and also our study timeline has blown out a little bit. So I'll talk today just in particular about these top two, just to give you a little bit of a snapshot of where we're at. So in terms of our facilitator data, this data was captured as part of a national data collection project that Smart Recovery started back in 2016, I think it was, or 2018, sorry. And then as part of this project, facilitators, so that's one thing I didn't mention, is Smart Recovery is run by a trained facilitator. Facilitators captured non-identifiable information about attendees. So we've got these characteristics here that they logged at the end of each group. And we've got this one here, proof of attendance, as a bit of an idea as to whether or not people are attending for themselves or whether there's perhaps some kind of legal mandate. We also got them to rate entitativity, which is a single item, that's this item here, about how well the group was working together. So here's the rater in the middle, and then on the outside, we've got the participants. So the further away the participants, the lower the entitativity, so groups are working more poorly, and here's a good sign of cohesiveness. In terms of some key findings, do people who use methamphetamine attend Smart Recovery? They do. So over this particular data collection project, in almost 4,000 Smart Recovery groups consisting more than 22,000 attendees, or attendances rather, we had 22% of people attending for methamphetamine. And then when we look at the proportion of the group members who are attending for methamphetamine, we've got 58% of groups had one or more people. In terms of characteristics, we've got more men attending for methamphetamine than other behaviours. The reverse is true for female. Younger age groups, more for methamphetamine than other behaviours, and reverse was true for the older age groups. Not much difference, but a trend towards methamphetamine being more likely to come back to that group, and then not a lot of difference in terms of whether or not people are attending for legally mandated reasons. In terms of location, we've got more methamphetamine related attendances in rural groups relative, and the opposite true in metro and online. In terms of our entitativity, we've got, so 0 is not good, 6 is the highest rating that you can have. We've got really solid ratings of entitativity, irrespective of how many people are attending for methamphetamine. So from the perspective of the facilitators, the groups are really working well together, irrespective of whether or not people are, irrespective of the number of people attending for methamphetamine. In terms of our participant survey, this is one of the slight changes that we've made. So now we're doing, at the moment, an online survey after people have attended online groups. So I should mention that all of the face-to-face groups for Smart Recovery had to shut down courtesy of COVID. Smart Recovery did a fantastic job of being able to transition a lot online, so it can still provide treatment and support throughout COVID. So for this particular survey, none of this is statistically, this is just a quick snapshot to give you a sense of where we're at. But we've got some descriptive information. So 440 respondents so far. We've got 13% attending for methamphetamine. So we're still seeing that even though it's transitioned to online, people are attending for methamphetamine. And the gender and the age, similar trends to what we've got in the Facilitator data. This one here is about some of the characteristics that we ask about people's experience with the group, the proportion of survey respondents who are on the agree side of a like-it scale. And we've got pretty positive ratings across all of these items that people, irrespective of whether they're attending for methamphetamine or another behaviour, are feeling welcome and understood and supported, and they're also receiving practical skills. Part of our methodology that's ongoing, courtesy of COVID, is our qualitative interviews. And so we've got only 6 more people that I need to interview before we can get a more detailed snapshot of how people are engaging with smart recovery and how they came to be involved, and how to improve treatment and support. So some tentative findings, but really promising in that we're seeing that people attend smart recovery, that the groups work well cohesion-wise. We've got some preliminary information around some of the characteristics associated with people who attend, that it's experienced as a positive, helpful skill building experience. And so our hope is that we'll be able to use this data in combination with our qualitative work to be able to improve access to and engagement with smart recovery groups, but also possibly use smart recovery as a springboard to link people in with other treatment and support. And also, given that smart recovery offers support to people with a range of addictive behaviours, our hope is also that smart recovery might be something that can potentially support a more diverse group of people, from people through casual use through to perhaps dependence. Thank you very much. And apologies for technical issues, and thank you for sticking with me.
Thanks so much, Alison. We've got time for one question, if anyone has any. I can't see any questions there. Really great to see some research around smart recovery, the smart movement. We do know that many of our clients access that, and it really is great to have a little bit more research around that and look at how we can better incorporate it perhaps in our practice on a daily basis. So that's great to see that you're doing that, and really looking forward to the next steps with that. Now, I'd like to introduce Victoria Manning, who's the Head of Research and Workforce Development at Turning Point in Melbourne, Australia, and also Associate Professor of Addiction Studies at Monash University. And she'll be talking to us today about the Methamphetamine Approach Avoidance Training, MAAT trial, a randomised controlled trial of personalised approach bias modification for methamphetamine use. So over to you, Victoria. Just reminding everyone that send through any of your questions, and we'll have a couple of minutes at the end to answer them. Thanks, Victoria.
Thanks, Nadine. Hi, everyone. And also thanks for having me as part of the symposium. So yes, I'll be talking about the MAP trial, which actually is the acronym. You've got to have a good acronym for a trial these days, and that stands for the Methamphetamine Approach Avoidance Trial. But we're actually using an approach called approach bias modification, which is also known as approach avoidance training. So according to the dual process model of addiction, the paradox of continued use despite experiencing harms and often a strong desire to quit can be explained by an overactive automatic motivational system driving impulsive behaviours, and an underactive top-down reflective system hampering one's ability to monitor and regulate behaviour and inhibit those impulsive actions. And as a result, behaviour becomes increasingly influenced by cognitive biases, which includes attentional bias, so that's the tendency for our attention to be automatically directed toward drug cues in the environment, and approach bias, the automatic tendency to be influenced by those cues and to approach rather than avoid them due to their attributed motivational significance. We see a stronger approach bias in those who tend to be drinking at heavier levels, and it's also been shown in a number of studies that it can be a predictor of relapse. So whilst most of the psychosocial treatments that we use for the treatment of methamphetamine use disorder, like CBT, aim to strengthen those sort of top-down reflective processes, they generally fail to address and therefore leave intact these cognitive biases that drive impulsive drug-seeking behaviour. But the good news is that there's been a number of trials now showing that approach bias can be reversed or changed to an automatic avoidance bias with this training called approach bias modification. As you can see from the table there, most of the research has been conducted in the context of alcohol treatment, either during sort of short episodes of resi rehab or detox. And the rates of relapse are generally lower, of somewhere between 8 and 13% 12 months after training, when it is indeed added to treatment. And we recently showed that when adding it to inpatient alcohol withdrawal, it shifted an approach bias to an avoidance bias, and also reduced relapse by 17% post-discharge relative to a sham training control group. So it's now being introduced into some withdrawal treatment services in Victoria. But unfortunately, today it's only really been looked at into very small studies in terms of other drugs or other drug-seeking populations, treatment-seeking populations. So with approach bias modification, participants are trained to repeatedly avoid methamphetamine cues and to approach non-drug cues. But they're instructed to attend to an irrelevant feature, and usually that's the frame around the image rather than the actual content of the image itself. So they're instructed to push on the joystick or push the joystick forward when they see an image with a portrait frame, which shrinks the size of the image, simulating an avoidance motion, just like that, and to pull on the joystick when they see an image framed in the landscape orientation, which zooms in on the image, simulating an approach motion like this. And so in the training, 95% of the time, the portrait or avoid trials will contain images of methamphetamine, and in this and on 5% of occasions something neutral, in this case fruit and veg. And then 95% of the landscape images, which are the approach trials, will contain the neutral images, and 5% of the time they'll contain images of methamphetamine. So in a single detox ward, we gave this training to 47 clients to explore feasibility, acceptability, and relapse prevention effects, and found that it was pretty well tolerated. Acceptability was good. Most, all but 4 continued to do at least one training session. We had 4 withdrawing because they found the images a bit too triggering. In terms of acceptability, we got reasonably high scores. Cravings reduced significantly, and the outcomes were much better than we typically see after a period of inpatient methamphetamine withdrawal. So 2/3 actually reported no methamphetamine use 2 weeks post-discharge, and just over half of them reported no use 3 months after leaving the wards, which is approximately double the rate that's reported in the MATE study, the largest treatment outcome study for this population. So on the basis of these sort of early promising findings, we applied to NCCRED to do an RCT with clients going through detox and a short-term resi rehab, comparing approach bias modification to a sham training control condition, so we can really get a sense of its effectiveness, but also for the first time to run an approach bias modification trial that's personalised, personalising both the methamphetamine images as well as the sort of approach images. And we thought that doing this, or we're hoping that doing this will increase both engagement and ultimately the effectiveness of the adjunctive intervention. So before participants in the trial actually commence the training, they're asked to rate 50 methamphetamine images based on how much they remind them of their use or times that they've used it. And this ranges from 0, not at all, through to 100, very much. They're also asked to rate 50 positive images based on how much they relate to their goals, things they enjoy, things that they'd like to spend more time doing. And as you can see here, the images depict things like exercise, family, friends, hobbies, recreational activities, travel, etc. And the images were actually selected in 2 focus groups with consumers who have lived experience of methamphetamine treatment from the Association of Participating Service Users down here in Victoria. They helped us, they sort of guided us on the images. They actually selected the most appropriate images and also assisted with other aspects of the trial design and materials. So in the active personalised training condition, the 10 most highly rated methamphetamine images and the 10 most highly rated positive images are then used in the training. So 95% of the time, they're pushing away meth images and they're sort of pulling towards them the positive goal-related images that they've selected. In the sham training control condition, they're not personalised. They just see a random presentation of 40 of those meth images, 40 of those positive images, and they're displayed 50% landscape, 50% portrait, so that there's no actual approach avoidance training for that group. So this is essentially the schedule. We recruit participants to the trial in week 1, but we don't actually commence training until week 2, when generally people are a little more stable. And then they do 3 sessions a week over the next 2 weeks, and then they're followed up by a researcher who's blinded to the treatment allocation or the condition allocation 1 month and 3 months after they've left that sort of 4-week detox and resi rehab period of treatment. The primary outcome is actually abstinence from methamphetamine at 3 months. But as you can see there, we've got baseline measures of methamphetamine use disorder using the SCID, methamphetamine use using the timeline follow back, the SDS for dependence, and we also look at measures of craving. We're also measuring approach bias to methamphetamine cues before and after training, and also look at craving at the subsequent follow-ups. And we keep a very close eye on changes in those sort of immediate craving scores after training, and we can get support from clinicians if people do feel triggered by the images. The intention is to recruit 100 participants across 3 different withdrawal units, 2 private and one public. So in terms of progress to date, we've completed the 2 focus groups with consumers, which was incredibly helpful. We've registered the protocol with ANZ CTR. We've submitted a protocol paper, which should be accepted any day. That's under review, or it's been resubmitted and under review. All the ethics and governance approval has been secured, and we commenced recruitment. This is just typical. We had our first participant recruited in the middle of March, just before things got messy, and we had to obviously stop having researchers going onto the wards. But I'm pleased to say we recently recommenced recruitment, and we now have 6 participants in the sample, and on that basis we think we'll hit our targets in about 10 months time. And we're really hoping if we can sort of replicate what we've seen when this training is given to people with alcohol treatment, that it will be a very useful, low cost, non-invasive intervention. It's very simple. It requires just a laptop and a joystick, no specialist skills needed to administer it, and it's something that could potentially be used across multiple different treatment settings. So I'd just like to acknowledge the co-investigators in the team, the staff and clients at the sites that we're recruiting from, to thank NCCRED for funding the trial, and everyone else here today for listening.
Fantastic. Thanks, Victoria. And in the last minute, we've got a question for you. Given that the approach bias modification was delivered in detox settings, how much of the reduction in cravings could have been attributed to the natural decline in craving over time as opposed to the intervention?
Probably a lot of it. That was just a feasibility study, and we didn't have a control group in that pilot study that I presented, which is why in this trial we will indeed have a control condition. We'll be measuring craving through questionnaires as well as through a visual analog scale immediately before and after training. But yeah, absolutely right. You'd expect craving to decrease over the course of methamphetamine withdrawal treatment.
Right.
Yeah.
Excellent.
It's good.
Certainly sounds like fun, having a joystick, something to play with.
Well,
whether it works or not, it doesn't really matter.
It's about the only use for them these days.
We can get them cheap.
They're actually becoming quite hard to get hold of though. So we need to investigate, we need to invest in other ways of measuring approach bias. Yeah. Online and phones and things.
Just your finger on the screen, huh?
Yeah, exactly. We're doing that now with an online, a mobile delivered approach bias modification training for alcohol, but it could be some time before we can go there with illicit drugs because of storing images on, the platforms like Google Play and Apple and stuff. But yeah, that's where it's heading, hopefully.
Okay, all right. Thanks so much, Victoria. We move on to our next speaker, who's Adam Rubenis. And Adam is one of our first NCCRED research fellows, and he's a psychologist at the Statewide Clinical Services with Turning Point at Eastern Health, as well as along with Victoria. And his project is looking at the collaborative development of a clinician-administered checklist to facilitate retention and therapeutic engagement in substance use treatment. It sounds like a mouthful, but I'm actually really interested to hear what you've got to say, because engagement is we know engagement is such an important part of the success or not of intervention. So I'm really interested to hear your projects. Over to you, Adam.
Thanks, Nadine. Let me just pull up the presentation. Okay. So yeah, the presentation is, the name of it is a little bit of a mouthful. Hopefully, is this coming through all right for everyone? Are you seeing my presenter view?
Can you, are you able, we can see your slide and the next slide and all of the rest of the slides.
Oh,
If
so
you're
it's
able
on
to actually,
presenter view.
yeah,
I
change
might-
that, and then the next one again, yeah.
Right.
Go. If you go to presenter view, it should work, shouldn't it? Yeah. No, go to presenter view. No, if you go back.
Yeah. I don't know if it's
You
just...
go that one. If you click on, see it says presenter view.
Is that doing it, or... It's just I've got the two screens and it seems to not be cooperating. If I just play it normally, oh, it's going into presenter view.
Adam, if you just click swap displays, it's up top in the top left hand side.
Oh, okay.
Yeah.
All right, better.
Thanks, Gemma. That little voice in the background is Gemma, who is our project officer, who is, we're very grateful to everything Gemma does. All right, over to you, Adam.
Yep. Thanks. So yeah, as Nadine mentioned, it is a little bit of a mouthful, and I've got a fair bit to cover across this 7 minutes, because I was hoping to give a bit of an overview of a lit review that I've done in the area around low cost retention strategies, but also talking about developing a checklist that can be used by clinicians. So I guess through my clinical work, I've developed quite a bit of an interest in why people drop out of treatment, because we do know that a number of different psychosocial approaches can be effective if people do attend treatment. But the stats tell us that 40% of those that start AOD treatment in Australia don't complete their episode of care. And for methamphetamine specifically, you can sort of see 68 to 76% attendance for 2 sessions, and then it drops off quite a bit even just for 4 sessions. There's 33, as low as 33%. So there's definitely a bit of room for improvement there. And also, as many of you are probably aware, the AOD treatment sector is pretty stretched, meeting sort of 27 to 56% of demand. So I kind of saw this and thought, okay, there's probably quite an opportunity to try to increase, I guess, the efficiencies with the current resources that we have. And in thinking about this further, I thought that I'd do quite a brief sort of scoping review of the literature, looking at a range of different retention strategies that have been used across a range of vulnerable groups, and seeing whether any of these strategies have been applied to the drug and alcohol setting. And because there are so many different retention strategies out there, I tried to, I guess, consolidate them into just 4 different themes that I'd use to frame my analyses. So the first theme here was pre-treatment, which is what's done between clinician and client before the first session, mostly sort of focusing on role induction, which is giving the client an understanding of what to expect from treatment, overall recovery trajectories, but also responsibilities and expectations. So in terms of what I found in the literature, it seems like there is potentially a bit of a benefit between of verbal feedback over written feedback when provided to clients before treatment. That face-to-face sessions can result in small improvements to attendance. More intensive interventions can be a bit more effective. Then we had another category, autonomy and ease of access. And there were a couple of studies, and sorry, this is referring to the ease with which a client can access a service. So availability of assessment, appointments, appointment times, and that kind of thing as well. And there were a couple of studies that suggested fairly intuitively that less wait time results in a higher likelihood of attending early appointments. But then there was one study that found the opposite relationship for long-term retention. But you see, it's sort of pretty small numbers of studies that we're talking about here. Then also between sessions, prompts and reminders. So we know already that SMS and telephone reminders are used quite widely, and they look to have, it looks like they do have a small benefit, particularly early in treatment. And then combined approaches is sort of more of a catch-all kind of category. And, you know, we have one category here, treatment contracting, prompting during therapy, and then social reinforcement as having some benefit in the first 3 months of treatment. And then other studies that have looked at multiple engagement strategies found some increased levels of engagement for people who dropped out of treatment. So what I took away from that is that obviously there were only about 20 papers that I found looking at substance use specifically, let alone methamphetamine. But there's a lot that we still don't know. But I guess I was trying to look at it through a clinical prism and thinking about what are the positive characteristics of these interventions, and you know, and how can we actually use these. So I tried to have a look at it through looking at implementation science and the capacity to be adapted, trialed, you know, cost and the design, because we do sort of know that even if even if we've got these interventions that have got a small effect size, they can be quite cost effective if the burden on the clinician is low. So with all of that in mind, I've been trying to think about a way to integrate some of these strategies into a tool that clinicians might be able to use. And also trying to bear in mind the common factors model of therapeutic engagement. So, you know, so thinking about things like, you know, goal consensus, empathy, alliance, and that kind of thing, seeing if we can draw all of that together. And I did 15 qualitative interviews with clinicians who identified a few concerns to implementing these strategies, and that was mainly time, the need to be able to individualize treatment, but also that some clinicians may have issues changing with changing practice. So what I kind of ended up trialing was a checklist. And this checklist is certainly not intended to be prescriptive. It's not something that a clinician would need to look at and sort of tick off every single point in every session or anything like that. It's meant to just be a handy thing that someone can refer to and add on, you know, these checklist items if appropriate. You know, if it seems appropriate for the client, if it seems like it could be helpful. And I've tried to categorize these different points according to whether it's, you know, the kind of stuff that's happening early in therapy, so the role induction, or if we're looking more at collaboration and agreement between client and clinician, but then also the ongoing engagement, SMS reminders, support after completing treatment, but also talking about things like social reinforcers. So in terms of where things are going from here, I'm going to try and continue the co-development of this tool with clinicians. The clinicians that I previously interviewed, I'll email out to them for some feedback. I've also been talking to some of my colleagues at Turning Point, and I'm hoping to get off the ground sort of like a mini feasibility and acceptability trial for next year, just to get some really rich kind of qualitative data as to whether this kind of a thing might actually be useful in day-to-day practice. So that about covers me off. Any questions or thoughts?
Thanks, Adam. We don't have any questions, which is great because you're right on time, 12:45. So looking forward to hearing about the next part of your research, but that's an interesting approach for all of us, I think, in terms of therapeutic engagement, at least in some of the more talking oriented therapies. So thanks, Adam.
Thanks.
Moving on to Rachel Riley, who is a senior research fellow with the Novel Interventions to Address Methamphetamine Use in Aboriginal and Torres Strait Islander Communities, the NIMAC project. That's based in the Infection and Immunity Aboriginal Health South Australia Health and Medical Research Institute in Adelaide. Rachel, I'm hoping you're there. I haven't seen a signal from you. Yes, good. We are all sharing your pain and concern there in Adelaide, and I'm glad that you could join us today. And I hope the lockdown doesn't go too long for you there. And your project's an acceptability and feasibility study of the We Can Do This online therapeutic program in primary care and residential rehabilitation centres. Thanks, Rachel.
Thanks, Nadine, and thanks for having me along to this symposium. I'd like to start by acknowledging that I'm here on Kaurna country and pay my respects to elders past, present and emerging. And obviously wherever we are, in Australia, we're on Aboriginal land. I'd also like to acknowledge the cultural authority of any Aboriginal and Torres Strait Islander people who may be listening today. And I also need to let you know that this presentation contains the image of an Aboriginal person who has passed away, and their family have given us permission for us to continue to use their work in this project. So this NCCRED funded study of the acceptability and feasibility of a web app called We Can Do This is a really valuable addition to a larger project called Novel Interventions to Address Methamphetamine Use in Aboriginal and Torres Strait Islander Communities, or NIMAC, which is funded by the NHMRC. So I'm the study coordinator for this project, and I'm often the one who gets to talk about it, but I think it's really important to acknowledge that I'm here representing a much larger team. So this project is led by Professor James Ward, and we have an amazing team of investigators and, really importantly, site coordinators who are Aboriginal community-based researchers conducting this research on the ground in their own communities. So the broader NIMAC project commenced in 2016. And the first two phases were about collecting information. So we did a large cross-sectional survey of people who had recently used methamphetamine. And then we did a series of focus groups in 8 sites around the country. We talked to people with experience of use, Aboriginal community and family members of people who may be affected by methamphetamine use, and we spoke to service providers. And then that information has been used to inform prevention strategies. We're working with our partner Aboriginal Health Services in several sites around the country, and it's also been used to inform the development of the tool, which is the focus of this talk today, called We Can Do This. So developing this web app required input from a range of different people, as you can imagine. So we had a clinical advisory group who had identified the elements that they would view as essential to have as any part of a treatment program. We had a cultural advisory group who, along with the site coordinators, provided feedback about the cultural appropriateness of the content, the language, the style. And very importantly, we had a lot of feedback from people with experience of use, and they had a lot of say in the final product. So what we ended up with was a web app with 7 modules, incorporating cognitive behavioural approaches, some cultural reflections and cultural content, an exercise based on acceptance commitment therapy, which is about identifying your values and setting some goals to work towards them. And within each topic, the content is embedded within narratives that depict people at different stages of experience with methamphetamine. So these stories are from real people, and we worked with a local theatre company to bring them to life in little films, which sort of bookend and try and sort of showcase the content and make it relevant. So we're now in the process of trialling and evaluating the web app and seeing how it goes. So we're doing a randomised trial with people in the community. Anyone who's Aboriginal or Torres Strait Islander, 16 years or over, and is using methamphetamine can sign up to that trial. So the website there is there on the screen if you want to take a look at that. So we're evaluating that in 2 ways, whether it helps people to actually reduce their use and also whether it increases help seeking. But during the development process, it became really clear that this web app may in fact have a home also in a counselling setting, in rehab services and in primary care settings. So this is where NCCRED agreed to support us to assess the acceptability and feasibility of using the web app in those settings as well. Now, our main partners in the project are in Melbourne and Shepparton. And as you can imagine, with the year that Victoria's had and that we're starting to have, we've had significant delays in the project. So I don't unfortunately have any quantitative data to share with you, but I can share with you a little bit about what we're exploring qualitatively. and some of the very limited feedback that we've got so far. And hopefully next time I'll be able to give you a much more comprehensive account of what we've found. So acceptability and feasibility are constructs that can be further broken down. So with acceptability, we're exploring how engaging with we can do this makes people feel. Is it an effort to engage with the project? Does it align with your values? Do you have any concerns while you're using it about privacy or about the cultural appropriateness of it? Does the content make sense? Does it get in the way of doing other things? And that's what these little symbols around the side are supposed to represent. Do you perceive it as effective? Is it helping you achieve your goals? And how confident you feel in using it. On the feasibility side, we're looking at how often people use the web app, how long they spend on it, practicality, whether they have the equipment that they need in order to use it, whether there are fidelities or whether there are any changes that needed to be made to use it to fit with the service context. And integration, so was there any systems change that was required to incorporate the project into the service? And then we're also looking at asking clinicians and clients about specific feedback on the modules themselves, so design features and that sort of thing. So the feedback so far, as I mentioned, it's pretty limited, very preliminary findings. People have told us that the web app does make sense. They do view it as helpful. They feel pretty confident using it and it makes them feel good to use it. In general, it aligns really well with their values. One exception to this was the suggestion that for people who don't want to stop completely, the web app comes across as a bit too focused on stopping rather than reducing or cutting down or staying healthy while using. And this is potentially a bit off-putting for some. And this is important because with those narratives and with the content, we have tried to incorporate a range of experiences into the app. And we don't obviously want to feed into any stigma around methamphetamine use. So we need to be really sensitive and balanced in the messaging around the app. On the right-hand side there, in terms of feasibility, this is where participants have so far identified some challenges. And I was interested to hear, about the challenges in changing practice, because I think that is also reflected here. So finding time to use the web app in the midst of a already busy schedule and sort of program which is already full has been a challenge. In some settings, in a rehab setting, they did make changes to how it was developed. So they used it in a group setting. So rather than everyone using it themselves on their own device, they used it in a group setting and then people went away and used it themselves in private if they wanted to. And yeah, so that's basically where we're at. So a few challenges in terms of feasibility, acceptability seems pretty good. And the feedback we get from these interviews will inform the development of a clinician's guide that we're developing as an additional module within the app. And this will contain information about how it might be used as an adjunct to to counselling or group work. Then to finish off, I thought I'd just show you one of the videos from within the web app, just to give you a bit of a taste of what it's like. So this is our character Clinton, who stopped using some time ago and is able to reflect on some of the good things about that.
I felt like a king when I was using, because I had everyone eating out of my hands. I had them coming around and mowing my lawns. I had them cleaning everything up. It was because they wanted what was in my bag. I felt like a king. But I tell people today I actually am a king, because I'm a king to my family. I'm a king to my kids. I look after them. It's about me trying to. Like my little girl, she didn't see me at my worst. So yeah, I'm making good memories for her now. I feel like...
So that's it. So thank you. If you want more information, please do feel free to get in touch.
Thanks, Rachel, and thanks for that. I think that the possibilities that clinician-assisted tools like this open up are potentially enormous for us. It is, like all research, really hard to do the research and recruit participants and to get a sufficient sample size, and that's one of the limitations that we have with everyone doing small-scale research. And I'm hoping that going forward, we might have more resources to actually collaborate so that we can get some of this research done more quickly and not wait for the results, but we'll be really interested to hear the results. I think that's fascinating. Just a comment from Denise. That's a beautiful video. Yeah. Any questions from anybody? One question: what will be integrated in the research for more harm minimization for people who want to use safely versus people who want to stop use completely? From Denise.
Oh yeah, oh look, that's a good question, and I guess that feedback that we've received has really forced us to think more about that. We do have harm minimisation links to information and resources within the app, but it is true that I guess the target of this web app is for people who are looking to cut down or to stop using. So, but we're trying to sort of tread a careful line where we also provide that information within the app through links to other sites and that sort of thing. Great.
All right. Thanks, Rachel. I'd like to hand over to Annalee now, who is our discussant for the section. Annalee is the chair of the NCCRED Aboriginal and Torres Strait Islander Working Group and also a board member for NCCRED. So she's been, I'm extraordinarily grateful for Annalee supporting us in our journey so far. She's also a research associate and a PhD candidate at the National Drug Research Institute. So I'm really happy to welcome Annalee and thankful that she's taken some time away from a PhD to join us today. Over to you, Annalee.
Thanks, Nadine. Firstly, I'd just like to acknowledge that I'm on the land of the Whadjuk people of the Noongar Nation here in Perth. I acknowledge all the other Aboriginal people who may be participating in this webinar today. So yeah, 4 great studies have just been presented, each one contributing to knowledge to provide psychosocial support and treatment of methamphetamines. All the papers have discussed the development and evaluation of tools to be used for in treatment and support of both service users and clients and clinicians. First, we heard from Alison. She spoke about smart recovery and peer support programs having an important role in supporting participants and their families. And evaluations and reviews of these programs are vital because they've come from other, to address other drug issues. And I think that it's important that there's improving the links between smart recovery and the broader treatment sector has some great potential. And that improving the treatment support for people other than alcohol, but so in this case, people who are engaging in this space with other drug issues is really important and requires reflection and assessment of what's happening and what needs to change. And then we moved into the clinical treatment setting or detox setting with Victoria Manning's and her colleagues study, where they're trialling the use of avoidance approach avoidance training, which looked really interesting, and where it's designed, and this training is designed to dampen and the triggering impulses. Again, evidence has come from other spaces, and it'd be great to see the outcomes of this study. It's particularly as this, like other all of the studies, are low cost and easily implementable approach means it could be used across the sector, across the treatment of methamphetamine disorder. And I think enabling the personalisation of these treatments is really important and recognises that each client and individual has different experiences and needs that can impact their treatment experience. Next, we heard from our NCCRED scholar, one of our NCCRED scholars, Adam, who has looked at it from a different perspective and looked at what clinicians can actually, from a clinician perspective, what can be done to improve and facilitate the retention and engagement of clients while getting therapy. I think it's really important. His results, his study so far is the use of a checklist sort of can address the busyness that clinicians face including looking at actually having those discussions around the role, what their role is and what's needed from both the client side and the clinician side, and hopefully will ensure some of these approaches will ensure some ongoing engagement. And then thirdly, the work coming out of the NIMAC study, when we look, and I think Rachel's presentation on actually assessing the feasibility and acceptability of the study, of the tool that they've developed is really useful, and that this is working not just in treatment settings, but primary healthcare settings. And particularly with the move towards web-based things, acknowledging that there is things like internet connectivity issues and literacy can actually have impacts on these, and how do we address that? Each of these each of these studies is contributing some really important knowledge to the psychosocial support and treatment of methamphetamines. These tools are really important for both service users and clinicians, and they're addressing identifying some really important barriers that exist. So things like with smart recovery, that recognising that a lot more of our methamphetamine users are engaging in the treatment from a rural setting. I think because there's not a lot out in those rural, more remote spaces, so they are seeking treatment. That there's clinician skills and the clinician skills and capacity is different within each setting. So primary healthcare, those working in primary healthcare settings don't have this access necessarily to the specialised training and evidence. The personalisation of the personalisation that's in Victoria's presentation and that intervention, I think, is a recognising that all our clients are individuals with different needs and experiences, and that there's cultural differences that will impact on someone's ability to access or receive treatment or just engage in treatment. I think that all of these are really important. One of the important things of all of these interventions is that they're really low cost approaches. So I look forward to seeing the results of all these studies, as we've all been impacted with COVID restrictions this year. So that's it. Thank you, Nadine.
Great. Thanks, Annalie. Thank you for taking the last session before lunch. Before we do take our brief break, I just wanted to give a plug for the afternoon session, which, you know, what we're talking about outcomes. So how do we know that what we're doing actually makes a difference? How do we measure that? What are important outcomes for us and what are less important outcomes? So the first session this afternoon will be looking at outcomes. The second session will be looking at what next. So how do we know when the next problem drug comes along that it's a problem drug without waiting for multiple deaths or multiple harms to appear in the community where it's obvious to everybody? So looking at some of those early signal detections that we might be able to have a much more prompt intervention than otherwise. So thank you everyone for being here with us this morning. Thank you to all our speakers and presenters and discussants and chairs, and it's been really great to be with you.